Hey guys, it's me, Ree, and in this video we're going to be looking at an NMS-based case diagnosis. Um, this one is going to just bring up a bunch of the differentials that we see with a very basic NMS type of case. With this, note that some questions will be in a case format, but more so case formats are seen in part 3. So let's start with this patient. So we have a 20-year-old female rugby player. She complains of left wrist drop after colliding with another player during her game. Okay, so first thing we're thinking of, let's highlight some of the main ideas that we see here. So 20-year-old female. So it's a female. Sometimes that's important, sometimes it's not, but we need to know it anyway. It's a young female, 20 years old, but they're skeletally mature. Okay. Left wrist drop. So immediately we just need to know that it's the left side. And a wrist drop. So immediately I'm thinking, okay, what causes wrist drop? That should be a buzzword automatically that you guys are going, is this radial nerve? Okay, that's the first thing I'm kind of thinking of when I think wrist drop. Okay, after colliding with another player, she collided with another player. So what are things that can happen if someone collides? Well, that's traumatic. So this is a traumatic case. That is some type of traumatic event. So we need to know, did they hit their head? Are we fetching, is this something that's just muscular based due to trauma, or is this a neurological thing that happened during trauma? Okay. So that's the first step. So those are some of the main ideas from that first sentence. Let's keep going. She had sharp neck pain that radiates to the left forearm. So sharp pain in the neck that radiates or goes down the left forearm. So all the way from the shoulder down to the left forearm. She then has tingling in the lateral 2 digits on the left hand, weakness in left elbow extension, and has said, never felt anything like this before. She saw her PCP, was prescribed NSAIDs and muscle relaxants. She said that the NSAIDs do not help and the relaxants make her drowsy, so she comes to you because she wants to see if there's something else she can do besides take the medication. So I want you to take a second before we look at my differentials, and I want you to think to yourself, what would be the first thing you would in your office do for this patient? What would be some follow-up questions you would ask? What are some of the differentials that are already in your head? Okay? So when we look at this, I kind of drew out here. Here we have, this is going to be where she's getting that radiating pain. That's sharp in the neck, and it radiates down. And then we have this numbness and tingling happening in these 2 digits. And then here's that wrist drop that we saw. So, what are some things? So a C6 radiculopathy. So remember that C6, and we're going to talk about this in another video when we talk about radiculopathies, but C6 is going to come down right here on that lateral, the lateral aspect of the elbow, into the thumb, and into our pointer finger. Okay, so this is that pattern. So it could be that. But then I'm looking and I'm like, but it's this whole arm. So like, yes, there's some of this going on, but it's also impacting the arm. Is that just a reaction? What's going on? So that could be it. But what else could it be? It could be the whole plexus. So it could be a plexopathy that's focusing. So it could be all of our plexus, plus just a little more emphasis on the C6. What else could it be? Well, it could be peripheral entrapment of the radial nerve. Where are different areas where the radial nerve can be entrapped? Well, common area for trauma to happen to the radial nerve is in the spiral groove. So that's a common place that we see it. It can also be commonly impacted with our by muscles like our brachioradialis. So that's another area where we see the radial nerve impacted. It could be a cervical sprain or a cervical muscle strain that is just causing radiating pain. So how would I tell the difference between a sprain and a strain? Well, when I'm doing my testing, I would do O'Donoghue's, and I would look at, do they have pain passively and actively? First, you would do active range of motion, right? So bring your head down, bring it up by themselves, and then you do passive. If it hurts more with passive, that's telling me it's a joint or ligament problem. If it hurts more actively doing it, then I'm thinking it's more of a muscular problem. It could be a disc herniation, which could then cause a radiculopathy. So that could be it. Or it could be a TOS thing, which could be cause, again, all of these things. So what am I going to do on my exam? I would do my vitals. I would ask them questions to make sure they didn't have a concussion. Did you guys hit heads? Did you black out? Did you notice any changes in your mental functioning afterwards? Okay. You're going to do your motor sensory reflexes. So your motor, you're going to do C5 through T1, as well as the radial nerve, because we're kind of expecting that the radial nerve is impacted here. You're going to do your sensory for your roots and your radial nerve, your reflexes for your roots and your radial nerve. You might do a fundoscopic exam if there's some concussive issues. You might do the bruise of the head and neck because of concussive issues and because they had sharp pain in the neck. You're going to do range of motion. You can do this as an O'Donoghue's or just active range of motion, but I would do it of both the cervical spine and of the shoulder because, again, I'm not quite sure, is this correlated with the cervical spine or is this because of the shoulder? In New York State, you have to relate everything to the spine, so cervical spine would be what you would put down, but we, as clinicians, still want to know more specific. And then you would do cervical distraction, neutral compression if you're suspecting it's a cervical thing, shoulder depression. Now, you're like, well, what would I also test? How do I test the radial nerve besides these things? You can just touch where the spiral groove, and if that lights them up, then that might be what's happening. So that's another way that you can see if that's being impacted. So what would you do? This person is acute. Well, you would refer them to x-ray, make sure there's no fracture or anything like that, or a CT, because if they said they hit heads because of an acute head trauma. But usually you do some soft tissue, some heat, some mobilization, and laser. And if it's a radiculopathy, then maybe some HVLA. But again, you would have to have them cleared before that. So what you're seeing here is that we were able to use basically the first sentence to come up with basically our diagnosis. So they're going to give you what you need, but just make sure that you're thinking, what is my most likely based on what they're giving me? Okay, so it could have been cervical sprain and strain, but really based on these symptoms, not probable. What's more probable is a radiculopathy or a plexopathy, or the radial nerve, traumatic radial nerve entrapment or injury. So that's just showing you how a case kind of flows. You'll get a lot of this on part 3, where you'll have to kind of go throughout the case. Where also you'll have a lot of case management questions in the chiropractic techniques and practices section of boards, which we'll have more videos in the future. But I want to introduce this before I get into defining more, reviewing what is a radiculopathy, what is a plexopathy, what is a myelopathy, and then what are some of our neurological testing for cerebellum and for dorsal columns and for all of those things. So if you have any questions, please let me know. And in the next video, we're going to start in on radiculopathy.